Welcome, everybody, to this Cormendi webinar. I am Dr. John Stracks here in my office in Chicago. I'm here with Dr. Howard Schubiner, who is in his office in Southfield, Michigan?
Pleasant Ridge, Michigan.
Pleasant
Close
Ridge.
enough.
And Dr. Schubiner joined our practice a couple of weeks ago, so has been seeing patients. We are thrilled about that, and we scheduled this as a way to both talk about his movie, This Might Hurt, and answer questions that people might have. So we'll be here for the next hour chatting and answering questions. Anybody who has questions, feel free to type them into the Q&A button. We can see those questions starting to come in. Howard, as we get started, so first of all, I'm thrilled. Did I mention that I'm thrilled that you are working with us and seeing patients?
Me too. Me too. I was out in the cold.
Yeah. But we are just so excited to have your expertise and the ability for people to contact you and for people to contact you from all across the country at this point, not just people who are in Michigan. And so to celebrate your coming, we gave everybody the link to This Might Hurt, which a number of people have watched. And if people have questions about the movie, they can, you can type that into the question and answer box. But let's talk about the movie for just a few minutes as we get started with the Q&A. So how did that get started? How did Kent Marion first contact you about that?
Yeah, well, Kent wanted to make a film after his own personal experience with pain and reading one of Dr. Sarno's books and getting better, and then having pain pop up in lots of other places. And then he eventually, that was before he went to film school. He went to film school, became an editor. And then he had this nagging idea to make a documentary on this process. And he called Dr. Sarno to say, hey, Dr. Sarno, can I make a movie about you? And Dr. Sarno said, no. I think he'd already had a movie being made about him by Michael Galinsky. So Dr. Sarno said, you should call Fran Anderson or Eric Sherman, I think. And so he called, I think Fran maybe, I'm not sure. And she said, well, you should try Howard. So he called me. And he said, do you want to have a movie made with your patients in it? And I said, that'd be fine with me, but do you really think my patients would want to be in a movie? And he said, well, why don't you ask them? So I said, okay, brilliant idea. So I was doing groups at the time, and I had a group coming up. And so I sent an email or whatever to the people who were in the group, and they all said yes. So I said, okay, I guess we can do it. So that's what happened. And this was before Marion was involved. Ken came to Detroit. He hired people to do sound and lighting, I don't know, all this new movie stuff. And we just he shot the people, and a few people he got very interested in as the main characters. And that was it. And it took him 70 years to edit it.
But it's been out for a number of years now, right?
Yeah, it debuted at the South by Southwest Film Festival prior to COVID. COVID came, there were no more film festivals, and then it's been shown at a few film festivals since then, but mainly streaming to groups like Cormendi, like a variety of health institutions, some medical schools, some health professional associations, some patient advocate groups, and across the world. They just had a showing in Belgium. It was kind of fun.
Nice.
Yeah.
Nice. And your patients ultimately liked being in the film?
I think they did. I think so. There was the one woman who didn't like being in the group. I don't know if that had much to do with being in the film or not. But I think they felt special. I think I felt special. It's like, oh.
Yeah. I mean, it's really obviously really well done, and I think really nicely captures how you work with people and how we work with people and these ideas. And I think anything that helps this message get out to a wider audience is worth doing.
Yeah. Yeah, they were, Ken was particularly interested in the emotional processing work. So a lot of the film focuses on that,
Mhm,
so we didn't focus so much on maybe the writing exercises or the meditation
mhm,
work or kind of lowering the fear message and rewiring the brain part of stuff. There
mhm.
was some of that, but anyway, so he was happy because he thought the emotion work was, the, made the film more engaging and compelling, which,
Yeah,
you can, makes sense.
yeah, yeah. Good. Well, I'm glad, we got a lot of good feedback from people who were able to access the movie and watch it and hadn't seen it before. So we were thrilled to be able to offer this to people to get a chance to see it and see, how you work and how that group worked. So
Yeah,
very glad to that people could access it.
yeah,
Um, we have about 10 questions that have already come in. And so I want to spend some time whether people have questions about the movie or mind-body medicine in general. I want to start going through these and we'll answer as many as we can for over the course of the evening. Like I said, we'll end about 7 o'clock Central Time, 8 o'clock Eastern Time. But those of you who are watching, feel free to keep typing those questions into the Q&A and we will get started with. The first couple, interestingly, are about when these strategies aren't working. And so people who understand the concept, try to do the work, and don't find that they're getting a whole lot better. So the first question is, like, what do you see amongst people who try this and it's not working as well as they would like it to?
well, when people are not coming around, where their symptoms aren't getting better right away or after several months, even, certainly, I want to go back to the basics. Do we have do we have the correct diagnosis? Have we done a full assessment? Has no stone been unturned? Are we sure that this is a mind-body condition? And more importantly, are they sure that it's a mind-body condition? Because if there is doubt, and I've seen several people just in the last couple of weeks where, they've been working on it a while, but there's still some doubt in their mind. They still have some questions about it. So beginning back at that place, going back to the neuropsychological education, going back to the really understanding the ideas of predictive processing and making sure that they really understand that the brain is powerful enough to produce the symptoms. Because frequently the problem is the symptoms are so overwhelming to somebody that it's really hard for them to look at them as brain-based, which leads to the third problem, which is common, which is fear, which is continuing fear, continuing focus on the symptoms, continuing being frustrated by them, fighting them, trying to figure them out, all these kinds of things which kind of feed the danger signal. I call those the 6 Fs. And then, which leads to the fourth thing, which can be a problem, which is trying too hard. And so we see that a lot. And sometimes people have to take a break from trying to fix themselves and work on what I call the outer journey or their life, as opposed to trying to fix the problem.
Yeah.
Um, and then some people have some underlying issues of trauma, life trauma, or underlying other issues of fear that I saw a woman recently who was just tons of fear around the pain, but when I talked to her, there was a ton of fear in her childhood as well.
Mhm, mhm,
So that was another thing pointing to maybe that might need to be addressed.
mhm.
Um,
What are the 6 Fs that you mentioned?
the 6 Fs: the fear of the pain or the symptom,
Mhm,
the the focus on it, the monitoring it, paying attention to it, the fighting it,
mhm,
the being frustrated by it, the trying to figure it out. That's a big one. Trying to figure it out
mhm,
over and over and over again, every minute, every day. And then
mhm,
finally, trying to fix it.
mhm, mhm.
So those are the ones that tend to drive the danger signal in this vicious cycle. So those are some of the things that I see.
And I do think too that, when I talk with people, especially people who are stuck, And I'll ask the question, what do you think the pain is doing there? I ask that to people all the time. And almost always when people are stuck, the answer to that question will be, I don't know. And so I find it helpful, and this is ties into what you're talking about, that we understand that the pain is not the enemy, that pain is not trying to ruin our lives, pain is not trying to make our lives miserable. It's just trying to protect us. Pain is a protector. And I always find it significantly helpful if we can figure out where the protection is needed, and then we can look at that and figure out how to get protection in other ways besides pain. But it ties into the being frustrated and the trying to fix it. When we understand that nothing's broken, this is just our brain trying to provide protection, trying to work with us, then we can figure out how to work with the pain.
Right. Yeah. Is there a message that it's sending us? Is there something that might be happening in our lives that we need to change, something that we need to address, or some way that we're treating ourselves?
Yeah.
Let's the IFS question is, what what do you what would your pain be worried would happen to you if it wasn't there?
Mhm,
If it
mhm.
wasn't, quote, protecting you, what's it preventing you from happening to you? And
Yeah.
it's a lot of great avenues to that. Yeah, good point.
Yeah. So the next question is similar. So beaten TMS once, now with a relapse. Why is the relapse harder to deal with than the first time around?
Well, usually what happened is people got better quickly the first time.
Mhm,
And then when it comes back again, they're surprised, like they think like, okay, well, I know about it, so that's all it took.
mhm,
And then they do the same thing they did the first time and it doesn't work. And then they're like, uh-oh, then all sorts of fear and spiraling
mhm, mhm,
occurs. So it's not really necessarily more difficult the next time. TMS always occurs, but it's the question is, a lot of people don't expect it to occur, or they're afraid if it does occur, and they just may need to go a little bit deeper
mhm.
into some of the issues we just talked about.
Right. Yeah, I did an interview with a patient named David Holmes a few years ago, and David first learned about this about 30 years ago. He's a attorney here in Chicago, and when he first learned about it, he was better in like 2 days.
Yeah, right.
He had read Dr. Sarno's book and he gave the book to his mother-in-law. And then like 3 months later, it came back and he had forgotten. He'd forgotten how he got better the first time.
Right.
And so he was sort of preparing for a life of pain and suffering and no exercise, no movement. And he remembered what had happened. And he describes it. He says it's dramatic, but he crawled across the room to his computer because he was in so much pain.
Oh,
He
good.
brought up Dr. Sarno's website and he said he could feel himself starting to relax. But that second time, it took him months
Mm,
to get better because that's when he really realized what was going on underneath the surface and that he had some family issues he needed to deal with and some childhood issues he needed to deal with. And I've heard other patients tell me similar stories that the first time seemed easy, but then the second time was when they really recognized what was driving
yeah, yeah,
the symptoms.
yeah. Makes sense.
Um, Next question says, I've had pelvic pain for 13 years after surgery, and I get PT and they say the muscles are tight. What can I do?
Well, what's interesting is people say frequently, I saw a person today with this, well, is it the fascia? Is it the muscles? Is it the ligaments? Has something been damaged? And, there's no injury that doesn't heal. So acute injuries will heal. So when you have pain for more than months or certainly 13 years after a surgery, the injury has healed. Why are the muscles tight? Because the brain is making the muscles tight.
Mhm,
And so it's not that the muscles are damaged or diseased, trying to fix the muscles, trying to get the muscles to relax is kind of missing the boat in a lot of ways.
mhm, mhm,
And the PT is so focused on the muscles, it's putting more attention
mhm,
on that part of the body. And sometimes
mhm,
that can be invasive or uncomfortable. Sometimes it can make people worse, or if it makes them better, they see, oh, I'm relaxed, my muscles are relaxed, but then it keeps coming back because the underlying force of this dangerous signal in the brain is making the muscles tight again.
Mhm.
There's, of course, a famous study that Lorimer Mosley did with back pain, where he examined people very much detail onto the tightness of which muscles were tight and
Mhm.
which muscles were painful.
Mhm.
In some places, the muscles had no pain but were very tight. Other places, the muscles had a lot of pain, but there was no tightness.
Mhm. Mhm.
And
Mhm.
so the correlation between muscle tightness and pain actually wasn't really there.
Yeah.
So
Yeah. And so what strategies then are helpful? So there's muscle tension. And again, the tension isn't the point necessarily, but how would you approach it? What can she do that will help to calm the pain down?
Well, I mean, it's no different than approaching any other of the mind body conditions, whether it's back pain, pelvic pain, whether the muscles feel tight or not, neck pain. It's not worrying about the tightness of the muscles. It's not making that the issue. We're not trying to fix something because nothing is actually broken.
Mhm. Mhm.
So it really relates in a broader way, instead of focusing on trying to fix the pelvic pain or the tight muscles or whatever. It's broadening it up to, as we were just talking about, what you need to do in your life. How can you calm the brain, lower the danger signal?
Mhm.
Uh,
Mhm.
and, that's all in the work that we do. It's in, not to, it's in my books, it's in the
You can,
podcasts
you
you
can say that you
do.
have
I
a
mean,
book.
I mean, it's there. That's the work. But
Yeah.
it's no different from one thing to the other. It's like people say, well, like today, someone said, well, I have all this pain. I had this pain and that pain and the other pain. They keep
Mhm.
going back and forth, and then all the pain went away.
Yeah.
But then I was really depressed.
Mhm. Mhm.
It's like, okay, well, is that a different thing?
Right.
And the answer is no. It's the same thing. It's just a different manifestation
Yeah, that's
of its
interesting. I
underlying
just got
mechanism.
done with my last patient in the evening who pain got better and now he's anxious.
Yeah, exactly.
Same thing, different manifestation of the same underlying
Yeah,
issues.
yeah, right.
Next question says, do you see more changes 1 year post-treatment or 5 years post-treatment? Good question.
uh, Everyone's different. I don't know. I don't know if you mean more changes in life. Well, changes in life is evolving, right? I mean, changes in your life goes on. I was talking to somebody today, and she was talking about the personality traits. Perfectionism, being hard on myself, never feeling good enough, feeling guilty. Those are lifelong issues to deal with and to work on improving yourself. I told her it took me a long time to feel like I was grown up, which sounds silly, but it's true. And it wasn't until I was in my 50s where I learned I could say no to somebody, or I could stand up for myself, or I could not care if somebody said something about me, whatever. I could make a mistake and not beat myself up. It takes time to do that. And that's why we were talking a minute ago about the message and the symptom. I mean,
Mhm.
the symptoms are there to guide us. They're there as a message. In a way, they're there as a gift. And that's hard for a lot of people to get. Of course, I understand if they're
Mhm.
in a lot of pain or other symptoms, but if you can look and find the meaning, can be really great things for you. And it might take years to do some of that work to change who you are and how you relate to yourself and to others.
Yeah. I also think that, everybody's got their own pace of getting better. We've seen people get better in a couple of days. We've seen people get better in a couple of decades
Yeah.
and everywhere in between. And another one of the interviews that we did a couple of years ago with Jody Prado, Jody got better like 2%. I don't know if Jody's here tonight. Got better like 2% a year for 4 straight years.
Wow.
And um, what I say about Jody is that 4 years seems like a long time, right? I mean, she struggled with it and frequently during that time would talk to me and say, like, I don't understand, why am I not better? But but now she's better. And so she just messaged me last week, a couple times a year saying like, I can't believe that I'm better. This is amazing. And so sometimes it can seem slow, but she just kept improving and kept getting better. And so we can see a lot of improvement even years after people start working on this.
Yeah. Yeah. I saw a guy recently, it took 2 years.
Yeah. Yeah.
He got better, but it was a lot of work.
Yeah. All right, let's talk about some symptoms that aren't necessarily pain related. Fatigue. What's your thought when you're talking with people about how fatigue is related to a mind-body process?
One of the fascinating things I've learned over the last few years is that when you catch a viral infection, the virus itself can cause sneezing, runny nose, cough, pneumonia. But the fatigue that you get when you catch a virus is not due to the virus. The fatigue is due to the brain's warning system. The fatigue is due to the brain saying, slow down, buddy. Time to rest. You can recover. You have a virus. And it's shocking to people because fatigue is such a powerful sensation, but it's brain induced. And there are a few medical causes of fatigue for sure: hypothyroidism, hypogonadism, variety of things, severe anemia, et cetera, severe congestive heart failure, lung disease, et cetera. There's some medical things, but for most people, they don't have those medical things. And so we would treat fatigue in the same way we would treat other things. And certainly with long COVID, we've seen a lot of fatigue, and we've seen a lot of people get better by doing this work.
Yeah. And then what about GI issues? And so say food intolerances, bloating, stomach pain, all the tests are normal. And some of the other symptoms have gone away, but not these yet. Any thoughts about how stomach issues fit into all of this?
Yeah, I saw a woman today with the same thing, just like that. So many stomach symptoms, so much. There's just all sorts of different ones. But, again, all the tests are normal. So when the tests are normal and the symptoms are varied like that, the brain can produce any and all of these symptoms, certainly. And one of the things that, we always do is try to what I would call rule in a mind body or a neural circuit type problem. And we rule those in by paying special attention to the variabilities of the symptoms, the details of them, the characteristics, the turning on and off, the shifting and moving, the inconsistencies, the ones that are triggered by innocuous stimuli. And today I saw a woman who had a lot of GI issues with a variety of foods, and one of the foods was coffee. And so I had her close her eyes and imagine having a coffee cup in front of her. And she started getting pain and burning in her throat. Just imagining the coffee, not even imagining drinking it, just imagining it sitting there. And so that's a powerful demonstration of the fact that it's not the coffee itself, it's the brain's fear of the coffee.
Yeah. Other questions that are coming in. So we've got a number of them. What percentage of pain would you say is structural versus neuroplastic? What's your thoughts? I get asked that question.
Yeah.
So what's your thought about that?
Well, in general, I mean, everybody needs assessment and diagnosis and medical testing, et cetera. But if you want to ask, the answer to this question is relatively easy. If you take headaches, 95% of headaches at least are what we call primary headaches. So they're neuroplastic. Tension headaches, migraine, occipital neuralgia, daily chronic headache, et cetera. If you take fibromyalgia, 99%, it's rarely something else. If you've ruled out disease, fibromyalgia, irritable bowel syndrome, same. Pelvic pain syndromes, if you're looking at pudendal neuralgia, vulvodynia, coccydynia, interstitial cystitis, pudendal neuralgia, those are all neuroplastic problems. So very, very little pelvic pain is structural. And we did a study recently with back pain where a colleague of mine, as you know, evaluated 220 consecutive people with chronic neck and back pain using our model of understanding and delving into it and looking very carefully at the symptoms. And he came up with 88% of the people with chronic neck and back pain were non-structural.
Mhm, mhm.
which is a very high number. And of course, would be surprising to many doctors.
Yeah.
We just wrote that paper up. We finally wrote it up. We submitted it to a journal.
Mhm.
I found out today it got rejected without even being reviewed. So,
Without even being reviewed, like,
stab me in the heart.
all right, here's a good question about getting better. And so you think about neuroplasticity and retraining the brain. So you can retrain the brain, lower the fear, and decrease the attention, but
Yeah.
you can also release emotions. And so they're different techniques. How are they connected?
Well, they are different techniques, and they're related to different processes to a large degree. Um, but if you, in terms of being connected, they're connected by fear. For example, the woman I was talking to today had a lot of fear in childhood, had a lot of fear now. The fear in childhood had to do with family issues. The fear now has to do with the pain. So there's a connection there. We want to deal with the fear of the pain, but part of the fear of the pain is actually dates back to fear that was engendered in her life. So there's certainly a connection there. Um, Another way of thinking about it is we want to lower the fear of the symptom on the neural circuit retraining side or the pain reprocessing side of things.
Mhm,
We want to lower the fear of emotions
mhm,
on the emotional processing side. So if we can identify, recognize emotions, treat them as normal,
mhm.
not being afraid of anger, not being fearful of feeling guilty, not being fearful of being sad. Uh, that's another way to think of them in parallel.
Yeah, and pain is all about fear. It's when our brain has the sense that there's more danger than safety, then pain is potentially an appropriate response. And so part of our job is to figure out where the fear is coming from. If the fear is coming from the pain itself, then decreasing the attention and being more comfortable with what's going on in our body is an appropriate treatment. If the pain is coming from, or if the fear is coming and the danger from having emotions that we don't allow ourselves to have, then we need to work on that. If the danger is coming from the terrible things we're telling to ourselves in our minds, then we need to work on being more compassionate to
Exactly.
ourselves. And so getting a sense of what's dangerous for us and what's dangerous for me might be dangerous, different than what's dangerous for you. So we need to figure that out.
Right.
Uh,
Exactly.
yeah. Question about the movie. Tony had such severe leg pain. Do you know what happened to Tony?
I've been in touch with him over the years. Every now and then, he's had a lot of rockiness. He's had a lot of, his life has not been easy. When you see at the end, he's delivering pizzas for a 1 cent tip. I mean, you know, it's
Hmm.
things keep happening to him in his life. He went through a lot of stuff, but I think he's doing pretty well now. Last I heard, I
Yeah.
think he's doing pretty well. He's grown up. He has a child.
Hmm.
He's making his way in life. I don't know exactly how his leg is,
Hmm.
um, but you know, it was it was just it was just sad. It was really sad. The movie was really sad in relation to him, but
Hmm.
he's a he's a great kid with a big heart, and um, you know, my
Yeah.
sense is he's doing reasonably well now, but
Yeah.
I'm not
That's
100%
good.
sure.
The same person said that she is very much looking forward to the sequel. So, and finding out.
Okay, great.
Can you recover without doing any of the emotional work outside of reducing the fear?
Yes, of course, happens every day. Not
And,
everybody needs to do emotional
right.
processing work, even if there were emotional stuff, because what's maybe driving the pain now, as you just said a minute ago, is
Yeah.
fear of the pain itself.
Yeah. Do you have an example of somebody who like all they did is reduce the fear and got better?
Well, I mean, you read the book, pain goes away. Kent
Yeah.
Kent Bassett. I mean, there's hundreds of people. That's why, Dr. Sarno's books are still selling way above any books of any of the current generation people.
We got to
It's
write
amazing.
better.
I don't know. It's just great. You were saying today about Ezra Klein, people showering him with Dr. Sarno's books, right?
Yep,
Did
yep.
that
Yeah.
really
So
happen?
for those of you who are watching there, Ezra Klein runs a podcast in the New York Times that's one of the top 100 podcasts in the country, and he had Rachel Zoffness on as his guest today, who's a colleague of ours in San Francisco, and they had a really nice discussion about mind-body medicine and how this works and how pain is about danger and not damage. And I thought she did a really nice job explaining it. But it got started because Ezra, who's in his 30s, started complaining about neck and back pain on the air a couple of years ago and got flooded with Dr. Sarno's books over the years. And so finally has been looking into it. And it sounds like has been helping him too. It sounds like he's feeling better. So but I thought that it was really well done. Those of you who have access to the Times or to Ezra's podcast, it's definitely worth a listen. All right, since the film was made, do you think there's been more acceptance of these practices by mainstream medicine?
Yes. Well, I don't know. It's not the film, but over the last few decades,
Mhm.
John and I have been doing this for 15 or 20 years now. There's definitely been more acceptance by mainstream medicine. The word is definitely getting out, but there's a long way to go. I mean, mainstream medicine is a huge behemoth. Is that a
Mhm.
word?
Mhm. That
It's
is a
big.
word. Yeah.
And turning that around is going to take a lot of work and time and effort. But I definitely think we're moving in the right direction.
Yeah, I was telling somebody earlier today. So you and I, do you remember when we did the conference in Ann Arbor in 2009?
Mhm.
And we invited everybody we knew who was possibly interested in this as practitioners, and 30 people came, which was amazing.
Yeah.
We spent the day together and we had dinner and got to know each other, and it was fantastic. But Curable, so most people here know the Curable app. So they have a Facebook page for practitioners, and there are thousands of people who are interested. And so the number of practitioners who are obviously interested in this has gone up by a factor of 100 at least
Yeah.
in the past 15 years, which is fantastic. Now, there are more than a couple thousand practitioners in the country, and so there's still people who don't understand it, but it's been exponentially growing, and our goal is to make it exponentially grow more.
Right.
Another question about other symptoms, and so we talk a lot about pain, and we use pain as a marker for symptoms, but thoughts about this person type: reflux, cancer, autoimmune diseases, and those are actually three pretty good conditions to talk about just briefly. So reflux, what's your thought on reflux and mind body?
I think most reflux symptoms is mind body. I think you can certainly have reflux as an issue, but the ones that I've seen that is just reflux, if you take antacids or the PPI medications, it's controlled. And so the people we see who have reflux that's going on, and the medication isn't working and it's getting worse and worse, and the tests show maybe a little reflux, it makes much more sense that it's a mind-body condition in that situation.
Yeah. And, I've seen some data that says that everybody has reflux, like everybody literally has reflux into their esophagus, but not everybody has symptoms. And so it makes it very much like the discs in somebody's back, where everybody has them, but not everybody has symptoms associated with them. And so I would put cancer in a little bit different box. What about you?
Yeah, I agree. If you read Gabor Mate's new book and some of his writings, and he's saying that, oh, you have cancer. Yeah, I've noticed people with cancer have these personality traits. And in his movie, he had this cancer patient take ayahuasca and cancer went away. So there are certainly remissions of cancer. That's been well known. The immune system is related to cancer. That's well known. But in general, cancer doesn't fit the typical story or the typical timeline and characteristics of mind-body disorders. Cancer occurs in babies, cancer occurs at all ages, and cancer occurs increasing with older age. Well, all those things are different than the typical mind-body conditions that we see. And there's not great evidence, there's no evidence that I know of that changing your mindset is reliably going to cure cancer.
Mhm.
I've worked with a lot of people with cancer, and we've done meditation, and they've used cancer as a way to change their life and focus on what's important and all those kinds of things, which is all good and well and good. But to say that cancer is a mind-body condition in general, I would say no.
Mhm. And then what about autoimmune disease, which I feel like is sort of somewhere in the middle?
Yeah, definitely somewhere in the middle. We know that there's a whole field called psychoneuroimmunology. The brain can affect the immune system. It's well known. Autoimmune disorders have been found somewhat reliably to respond to mind-body type treatments. It's a great kind of middle of the road thing where you can use medical treatment and mind-body treatment. Um, I was just talking to a woman yesterday whose husband had ulcerative colitis, and she said he did mind-body work and he's fine now. So, there's no question that it can be helpful. Mind-body work can be helpful in those conditions, I think. But, they also have a structural component often.
Yeah. Next question is about how you know when it's time for back surgery.
Well, you would read David Hanscom's book. How do I know if I need spine surgery? That's the name of the book. It's a very good
Uh,
book. But
yeah.
I mean, if you have, we don't, operating on in general, back surgery for back pain itself, generally not a good idea. Back surgery for pain that's shooting down the leg, that's severe, that's associated with neurologic signs in people with large discs in that area, that can certainly work.
Mhm. And I think Dr. Hanscom would say that he wouldn't operate unless he saw a lesion that corresponded with the symptoms that people are having. But I also highly recommend his book, Do You Really Need Spine Surgery? As
Yeah.
a good way to think through that particular question. Next question is about medication and transitioning off a drug like venlafaxine, and can be hard to come off. And um, what's your thoughts about symptoms that pop up as you're weaning off the medication?
Well, you if the medication is, first of all, I don't recommend weaning off medication until people get better
Mhm.
in general, because when you start lowering the medication, there's a chance of activating the nocebo effect. So the nocebo effect, of course, is when if your brain thinks something will go wrong, it will go wrong. And so a lot of times the symptoms that occur when people wean off medications are not due actually to the weaning of the medication. They're due to the brain's fear of weaning off the medication. And so when you look online, so many medications are viewed as so dangerous to wean, and people are weaning in increments of the tiniest amount that couldn't possibly really cause difference in symptoms, but yet are getting symptoms when they take off, 1% or something like that. And that's due to this nocebo effect. So when people wean off medications, I'm not against weaning. I'm not against going slowly, not too slowly, but I'm not against going slowly, but I generally recommend that people have a lot of good talks and interaction with themselves and their brain as they're weaning, reminding themselves that they're okay. It's okay to reduce. They'll be fine. And a lot of that kind of self-talk, I think, is really important.
Yeah, yeah. Question about Lorimer Mosley um, and people's history and their emotions. He doesn't question the questioner says he doesn't really seem to buy into that aspect of mind-body medicine. Any thoughts about Lorimer and his approach?
I love Lorimer. Lorimer is a hero to me. He has been one of the great people in the world to do some amazing research on pain. I just mentioned one of his studies. He's done a great job of educating people about pain. So I think very, very highly of him. Um, on the other hand, it's true that he's not particularly bent toward the emotional side of things, and he pays a lot more attention to the neural circuit side, the brain rewiring, and the neurological kind of aspects. That's his bent, and that works for a lot of people, but not for everybody. So I think there's no reason why we wouldn't, bring in the emotional work as well. That's what we did in the movie, of course, and that can make a huge difference. He did ask Mark Lumley, my colleague, who we've worked on emotional awareness and expression therapy together, and he did have Mark write a blog post for his blog. Lorimer did, which I thought was really great. So
That is great. I
he'll
think
come around.
so. You and I were talking. This is a number of years ago when you were doing one of your first emotional awareness studies, and I was asking you how it was going, and you said, "Oh, gosh, it's kind of slow. Like it's really hard to explain these emotional concepts, and people are really slow to get it." And I said, well, of course they are. I mean, that's why people have pain, because the emotions are hard and they're hard to access, and it's difficult work. And you said, no, I'm not talking about the patients. I'm talking about the therapists that we're trying. And I think emotions are hard, and I think that's why they show up in our bodies. And I think that's sort of a universal experience. And so there are lots of people. I was at a training, you and I have both done a fair amount of psychological training over the years, and I was talking with one of the foremost mind-body therapists in the world who was teaching the training. And we were talking about what I did, and I said, yeah, we've had a lot of luck with migraines. And he said, oh, migraines? Like, no, that's neurological. I don't think this is migraines. And so even people who are in the field, it's hard for them to understand how emotions play in. It's as human beings, it's a difficult area, I think, for us to venture into.
We really don't understand the basic science that emotions activate the exact same regions of the brain as does a physical injury. So the power of emotions to produce physical, real, and severe symptoms is just as much as any in any injury. And like in that podcast today, the person being interviewed said, well, their pain can't possibly be only psychological. It's never only psychological. And I'm like, well, I've had only psychological pain. I can tell you that for sure. I don't know what she was saying, but again, people they want to hedge. They want it they keep wanting it to be structural. They want it to be biological.
Yeah. And so here's the next question is, can you have both? Can you have TMS going on and a tangible medical issue at the same time?
Of course, but it's not that common. It can definitely happen. I've seen it, and sometimes it's a little hard to tell. Some people have a significant amount of arthritis in knees or hips, and they're having pain, and we're trying to tease out how much of the pain is the structural and how much is the mind body, and we're doing everything we can. And sometimes it's certainly both. But in the study, like I say, the study we did with the chronic neck and back pain, it was 88% purely non-structural, only 6% combined and 6% purely structural. So I think a lot of times people say, well, I have legitimate, tangible medical issue. And that certainly, there are a lot of legitimate, tangible, all illness is legitimate, all pain is legitimate. So we should really take that aside. But structural issues, certainly there's a lot of those.
Yeah.
But when you really look at chronic pain, if you look carefully and if you really do the testing and the evaluation, it's not quite as common as people think.
Yeah. I think that, part of what I've seen over the years is that when there's a tangible medical issue, and sometimes it's hard to miss that. And so when we get into these situations, and maybe it is, maybe it isn't, like, David Holmes told this story on air where he called me and said he had a big lump in his throat. And I was like, oh, David's super savvy about all of this. I said, anything stressful going on in your life? He said, well, I just came back from my dad's funeral. And I said, I literally said to him, well, we don't have to be rocket scientists to understand that metaphor. He's like, yeah, but it's a really big lump. And I was like, all right, well, let me take a look. And so he walked in my office, and right, you could see the lump in his neck from across the room. And so we got it evaluated and treated, and he's doing fine. But it would have been irresponsible of me not to check that out. And people frequently will worry, and they have neurological symptoms and think they have multiple sclerosis. The times that I have diagnosed people with multiple sclerosis, it's been like, somebody, I said, can you walk across the room? And he just fell over. Or another woman, I said, let me check the strength in your legs. And she pushed up, I've had her push my hand up with her right leg and like to there. And they said, okay, now push with your left leg. And there was nothing. And so I always look for that if there are medical issues we need to see, oftentimes they're much more obvious than we would think. And that when you're starting to say like, maybe yes, maybe no, then it leans me much more in the direction of a mind-body issue than a structural issue.
Yeah, and sometimes things get overlooked. I saw a patient with 37-pound weight loss,
Mhm.
and he had an EGD and colonoscopy, but he hadn't had a CAT scan of his abdomen. And he and his wife were saying, oh, this is definitely mind body. He's just not eating that much because of the pain. But he lost 37 pounds.
Yeah.
Right. So we ordered a CAT scan of his abdomen, and unfortunately he had cancer of the pancreas. But, again, it was a very dramatic finding of severe weight loss.
Yeah, no, I talked to a patient this afternoon who had a white blood cell count of 20, and somebody had said it was in her head. I was like, that causes inflammation on that level. Let's get that checked out. And so, so that's part of your and my job, right? Is to listen to people and look at the evidence. And the two things that I say that I'm trying to do is, one, is there a physical abnormality that's so profound that you're not going to get better unless we take care of it? And so I say this all the time, right? If we get off the call tonight and I hop down from my desk in a trip and I break my leg and I call you, I don't want you to say like, John, it'll be fine. Just meditate for half an hour. Everything will be good, right? I want to get that taken care of in a medical way. Or in the David example, or the example you just gave, is there some condition that would be irresponsible of us to find and address? And hopefully none of us are 100%, right? We're human beings. We're not perfect, but we're both experienced clinicians. And so that's part of what we're trying to do, is to get a sense of, is there something going on that we really need to identify and take care of? The next question is similar to that. How do you find somebody who can help to sort this out, whether it's structural or a mind-body issue, and can you do it from a distance? Thoughts about how to help people do this evaluation?
Well, I mean, doctors, the kind of training we have as physicians is the kind of training all physicians have as physicians. So, people can and should be evaluated by their regular doctors. And then if there's, the question often is, how do you interpret that? How do you interpret, well, my EGD showed a hiatal hernia, but the stomach was normal and the pH test was normal. Then we can help interpret that from a distance. We don't necessarily have to do all the testing. We can read the neurologic exam, like you just pointed out. Someone has a very abnormal neurologic exam. Well, that'll be picked up by a regular doctor or a neurologist. And so when we read the report from a distance, we're able to, if we can get the records, then that's, we're able to make that evaluation from a distance because we have the data.
Yeah, and we're more than happy if people get in touch with our office at cormendiahealth.com. We're happy to help people get on our schedule and get evaluations, and we're happy to do that for whoever is interested in that. Do people tend to go up and down, get better sometimes before they get worse?
Or do they get worse before they get better? Both.
Thank you. I said that in the wrong part. Yes. Do people get worse sometimes before they get better? Thank you.
All the time. I mean, was it, when a kid has a temper tantrum, you start to ignore them, it's going to get worse before it gets better. The danger signal in the brain is there to scare us, to alert us, to message us. And if it's still worried about you, it's going to go up initially. You start to ignore it, it gets worse. This happens all the time, but it's a good sign. Frankly, it's a sign that this is the brain doing it. You changed your mindset, and the pain changed. Whether it got better or it got worse, it still changed.
Mhm.
It shows there's a cause and effect relationship there. So that can help people to be even more certain that they're on the right track.
Mhm. Yeah. Let's see. We've got, so every time we answer a question, we get three more.
Or at
We
least.
started with 13, now we have 27, and we got about 10 minutes. And so we'll answer as many as we can and then see if we can do this again at some point. But these are fantastic questions, and I am super grateful for people who are listening and sending them our way. So this is a story for somebody who had hip surgery and was working on it as a mind-body issue and found out that her hip joint had really, really deteriorated. But once she found out that she's going to have surgery, the pain got 50% better just in hearing that sort of here was a solution. And so it seemed like a combination, but oftentimes people describe it as either or. And so why do you think the language is difficult to talk about hybrid situations like that?
Yeah, it is difficult because we want certainty. We want black and white. And sometimes it's a shade of gray.
Mhm.
And I want it too. I want to know, is it structural or is it neuroplastic? I want to, but reality is that people are complex.
Mhm.
There can be certainly tissue breakdown. And, just because you have a physical disorder doesn't mean you can't also have a mind body disorder on top of it.
Mhm.
Of
Mhm.
course, of course
Yeah.
that can. You have MS, and then I saw a lady with MS, and she had all these other symptoms that were not really due to the MS, but they were telling her this is all MS. Well, she has MS, and we have to figure out what's the MS and what's the mind-body part as best as we can.
Yeah. Here's a good question. What do you say about people? What do you say to people who call this quackery?
I go quack quack. What can you say? I mean, people can say whatever they want.
Mhm.
I've been, denigrated. I've been yelled at. I've been, you know, called all sorts of things. I've been called irresponsible, and
Yeah.
anybody's titled to their own opinion, but we have randomized controlled trials showing the value of this work now.
Mhm.
We've got neuroscience showing the power and the nature of predictive processing, how the brain creates what we experience. We've got, you know, uh, just thousands and thousands of people who've had improvements. And so when you combine the anecdotal, the science, the neuroscience, and the randomized controlled trials research,
Mhm.
you can say whatever you want, but
Yeah. But the right, I mean, I am biased clearly, but I feel like the data is in our favor by far. And who did the dietary study? Is that Alicia Crum? Is
yeah.
that,
Mhm.
you know her?
Yeah.
She did an interview with Curable, as you and I have as well on their podcast. And one of the things she said that I really liked is that we need to stop arguing about whether the mind is involved in physical symptoms. Like that data is clear at this point. And so the question is not what, the question is how do we use this to help people feel better?
Yeah. Yeah. I mean, it's like there's activists in the world who want to deny that
Mhm.
the mind or the brain can affect illness ever at any time because they're so kind of threatened by this idea.
Mhm.
And there was a big piece by Natalie Scher. If people haven't seen it, they should look at it, from the New Republic on long COVID. Then there was a response to Natalie Scher by a whole group of activists
Mhm.
telling her why she was wrong, and then Natalie Scher responded to that. But it's a war. It's a long COVID war going on,
Mhm. Yeah.
and there's big stakes. There's money at stake, and there's a lot at stake, and a lot of people are suffering. So, we're just doing what we can to, make the world a little bit better place.
Yeah. So, all right, we're going to finish up with a couple of questions about a variety of symptoms. Small fiber neuropathy. Any thoughts about that?
Yeah, I've looked at that intensely, and the shorter answer is small fiber neuropathy is a mind body condition. There's lots of people who have positive biopsies for small fiber neuropathy who have no symptoms at all.
Mhm. Mhm.
And And we've seen lots of people get better with it just using mind-body techniques.
Yeah. What about interstitial cystitis?
Same. The reason people think that it's a structural problem is that you can get petechiae in the bladder, a little bit of blood in the bladder. This can occur with distension of the bladder in normal people. So in general, I've found IC to be a mind-body condition.
Yeah. And what about tension headaches that include feelings of weakness in arms or legs? Any thought about how that could be part of a mind-body syndrome?
Well, tension headaches are mind-body syndromes. Weakness in the legs needs to be determined. Is it neurologic muscle weakness, muscle weakness, or is it weakness in the absence of disease, in the absence of neurologic disease, as you were kind of describing earlier with the woman who, so is it what we would call objective weakness or subjective weakness? Subjective weakness would be mind-body.
Yeah. Couple more questions. How do you explain TMS to family and friends?
You don't.
Even my family?
Even your family, John.
Hi, Mom. My mom's here, by the way.
Oh, hi, Mom. I'm looking forward to meeting you. Yeah, I mean, even my family doesn't really buy into it by and large. So it's hard, Dr. Sarno said this. He said, don't tell people about it. They're just going to try to undermine you. They won't believe you. They'll tell you something else. They'll argue with you. And, if you have, it's a trust issue. If you have somebody you really trust, you really love, and they're listen to you, and yeah, you could try to explain it to them. But to try to explain it to everybody under the sun and people who are going to be rejecting it is just kind of futile sometimes.
Yeah.
I don't know. What do you think?
So one of my patients, I think, has a really nice approach, and she gets into a conversation with people about this. She says, there's a lot of really good data at this point, and I know an evidence-based app that explains it really well. I'm sending you the link.
Yeah.
That's what she says. And she says that's worked pretty well.
Yeah.
And so knowing what's our responsibility and what's our not responsibility, and knowing that there's a lot of resources out.
Right. Yeah. But sometimes our patients are looking for support from the people they love. And that may work great, and hopefully it works great, but sometimes it doesn't. And a lot of times people, you have to say, someone says, how are you? And you have to say, I'm fine. How are you? Instead of, well, my back's hurting, but I found this mind-body practitioner.
Yeah.
Anyway.
Treating depression this way, can you do that?
Absolutely. As long as the depression isn't due to structural disorders, as we mentioned before, like fatigue, thyroid problems, or other hormonal problems, etc. But the research shows, for example, 75% of people who get an antidepressant have a good initial response within 6 weeks. But 72% of people have the same response to a placebo medication. When you have the same response from a medication or a placebo medication, that tells you that this entity is treatable by a mind-body approach, which is harnessing the power of your own brain.
Numbness and tingling, that be a mind-body issue, even though it feels neurological?
Yeah, very common. Like small fiber neuropathy has numbness and tingling. A lot of people have numbness and tingling. Again, as long as the neurologic exam is normal. If it's numbness and tingling, but when you check for reflexes and muscle strength and sensation, those are normal, then it's not actually neurological. It's actually neuroplastic.
Yeah. And that's how I found out about this in the first place. And those of you who've listened to my podcast with Curable from 2017 describe how 25 years ago had all these strange neurological symptoms that nobody could figure out. And I went to see neurologists and hand surgeons and EMGs, and nobody could get a sense, but it was my life. It wasn't anything that was wrong.
Yeah, right.
All right, last question for tonight. Let's talk about long COVID for a minute.
Oh, yeah. Well, we've seen a lot of long COVID recently, obviously. I've seen a lot of people get better from long COVID. There's a great website called positivelycovid.org that I would recommend to people. Paul Garner is on that site, who's a British scientist who recovered from long COVID in a relatively short time by changing his mindset. There's no evidence that the vast majority of people with long COVID have disease. Most people with long COVID are younger, had mild COVID. They weren't in the ICU, they weren't intubated, they don't have ongoing heart or lung disease. You know, if you take away the people who have severe heart and lung disease as an aftermath of COVID, COVID is a virus. And when the virus heals, the virus heals. And the after effects are this long COVID syndrome, when you have people with headache, brain fog, can't concentrate, fatigue, stomach pain, food sensitivities, et cetera, et cetera, et cetera. These are the typical mind-body symptoms that we treat.
Mm-hmm.
So, you know.
Can you catch long COVID on TikTok?
Can you catch long COVID on TikTok?
Mm-hmm.
Well, you know, John's referring to the ticks that were caught by literally hundreds of teenagers in the last year from watching. It's a fantastic thing to read about, horrifying, but true and common. And, you know, you could call it mass hysteria, which is a pejorative name to call it that, but I don't know what else to call it, but it's symptoms that are contagious due to fear.
Mm-hmm.
And long COVID fits that so well. There was every right to be afraid of COVID because it killed millions of people worldwide. Fortunately, the damage the virus does now is way different than the damage the virus did initially.
Mm-hmm.
Initially, it was affecting lungs and causing people not to be able to breathe and dying. Now it's affecting the upper respiratory tract and acting more like a regular virus.
Yep.
So, but the fear of it really triggered a worldwide epidemic.
And there's a huge fear of long COVID, right? Most of my patients, when we talk about COVID these days, they say, well, I'm not worried about COVID because of what you just said. It's acting like a upper respiratory virus. It's like, but I'm so scared of getting long COVID, right? It's there in what they're saying, that the fear is present. The first two patients who came to me with long COVID, neither of them had COVID, multiple tests. Right. Everything was negative. Tests were negative. Antibodies were negative. And so it doesn't make sense that you could have long COVID if you hadn't had COVID, unless you understand that this is a disease of fear.
Exactly.
And then it makes total sense. And one of the people I said that to, and she's like, wait, it's like that doctor from New York, the studies. I was like, Sarno? She's like, I love that guy. She's like, you mean I'm okay? It's like, yes, you are okay.
That's great.
Go live your life. And then so people
one of the things that happens is that when if we can get the word, and this may not happen, we can try, but if we can get the word out that long COVID is a mind-body disorder, it will vanish. Because people at some level, they're not going to get a syndrome which they know is a mind-body syndrome. So it's kind of
yeah. But for people who have it currently, what can they do? How can they get better? What have people done?
Same thing, same thing. Really go to our websites, read our materials, see us, use the apps, listen to the podcasts. There's tons of material out there, tons of online programs, tons of resources from the ppdassociation.org, the tmswiki.org, and all the other associated practitioners who are doing this work. Because the work is the same. It's no different than if you're treating any of the other mind-body conditions.
Yeah, I had mono when I was in college, pretty bad. And I came back to school and I was a varsity athlete and was trying to exercise and work out, and I just couldn't do it. And it was interesting because I knew somewhere in my brain I was okay, but I couldn't find my way through it. And then just had to keep putting one foot in front of another and keep doing the activities and keep getting back to what I was doing. And it took a while, but at some point I was just back to what I always did. And so when we recognize that we're not sick and what we feel in our bodies isn't a reflection of disease, but fear and worry and uncertainty, we can keep taking those steps and we can keep moving forward and keep trusting that we're okay and that we will get better.
Yeah, and it may take time, but most people have mind-body disorders in their life. Most people recover from them, whether they knew it was a mind-body disorder or not, because we have a strong mechanism within us to heal and recover and get back to equilibrium.
Yeah. So, all right, we've run a few minutes over, so I don't mean to keep you from the rest of your evening. Thank you so much for joining us here at Cormendi. Thank you so much for joining us here this evening. We got through 28 questions and we only have 23 left. So we'll have to get back on here at some point and keep trying to help people sort through this. In the meantime, feel free, obviously, a lot of you are our current patients, those of you who are, those of you who are not, go ahead and contact us at cormendihealth.com. We're happy to get you in touch with Dr. Schubiner or me or anybody else on our staff.
Great.
So
Thanks
thank
so
you
much,
so
Tom.
much. Nice to see you. Have a wonderful evening. Thank you all to all who joined us and were with us this evening and for your insightful questions. And it's always such an honor to be around a group of people who are brave enough to look at disease in this nuanced and an insightful way. So thank you. And I hope everybody has a good evening and a good rest of your week.
Bye, everyone. See ya.